Hello, I'm Alistair McClellan. I'm the editor of HSJ. Welcome to the HSJ webinar on the NHS long-term plan and no doubt many other related things. Now, let me be straight. This webinar is brought to you this morning under a certain amount of extremis. I have got a stinking cold, so apologies for the coughing and sneezing that will ensue during the next hour. Much more significantly, I was due to do this webinar with Dave West, HSJ's deputy editor. Unfortunately, Dave is currently nursing his 5-hour-old second son, so perfectly understandably is not able to be with us. Those of you who know him might like to tweet your congratulations, but never fear. HSJ's resources, expertise and connections run deep. So to help us in this webinar, we've got Adam Doyle, who is the Chief Executive of the East Sussex and Surrey CTGs.
Sussex and
Sorry, I knew I was going to get it wrong. And the Sussex STP. We also have Sean Linton, who is one of HSJ's bureau chiefs, and as almost everybody will know, one of the country's leading commentators on care quality and safety. And finally, once the taxi has delivered him, we will be hearing from James Illman, who is our senior correspondent who covers emergency care. Now, we're going to give you, as quickly as we can, what we think the key highlights of the coming year are going to be in a range of areas. We're going to ask Adam to comment on a couple of those, but we will try, given that we're attempting to cover a very broad range of subjects here, as many of your questions as we possibly can. You should be able to see on your screen a little button which allows you to ask questions. So as and when you have questions, please do so. I've got a little iPad here which will show me which questions to ask, and our job will be attempting to get through them as quickly as possible. Now, at the risk of destroying the magic of the webinar, you'll forgive me, I'm sure, while I refer to the notes that Dave emailed me at 3 o'clock in the morning, which were the notes that he would have spoken to were he here. So Dave is our expert on the long-term plan. He's been following it very closely, ever since the 5-year forward view. And what he's done is distilled it down to the 4 things that have changed since the publication of the long-term plan. Not necessarily as a result of the long-term plan, but just the 4 things that have changed since the publication of the long-term plan in January, and the 4 things that remain constant, remain important. So the first thing that Dave draws attention to is that in this current financial year, there is a little bit more money around. This is the first year of the new funding settlement. It was very much front-loaded, so there is a bit more cash around. However, the starting point in many healthcare economies is pretty demanding, with most trusts and many CCGs in deficit. So although there is slightly more money around, the position that the NHS is starting from is a pretty rocky one. The second thing where there has been really significant change is the focus on primary care networks. When I spoke to Simon Stevens at the start of when the 5-year forward view was published, 5 years ago or so, I commented to Simon that the unique thing about this current reform cycle was that it depended on a fundamental change in the way that primary care services were delivered. Uniquely, of all NHS reforms since its creation, and that if it was successful in doing that and not successful in doing anything else that it tried, it would be a success. And if it failed to do that but did everything else it was trying to do, then it would be a failure. and Simon agreed with me. So we are, and it's been a long time coming, the vehicle that will deliver that change. But primary care networks appears to Dave and to myself to be the vehicle that has the greatest chance to do so. And we might discuss with Adam why that might be. He may well disagree with me. Thirdly, we have got, hopefully, more consistency in regulatory and system planning as NHS England and NHS Improvement go through their merger, which we're not allowed to call a merger, particularly at regional level. Time and time again, HSJ readers have told us that one of the things that they find most difficult is the dissonance created between NHS England at a regional level telling them one thing and NHS Improvement telling them something else. Now, hopefully, especially I think because we're going to have one finance director at a regional level, that there should be more consistency of messages. But again, Adam might like to comment on that. The other thing that's changed is technology. There's a lot going on in technology, more going on in technology, I think, than any time since I began as editor of HSJ in April 2002, even more during the national programme for IT periods, because more's happening at a sort of local level. I'm going to speak to that in a little bit. So those are the things that Dave thinks has particularly changed. What are the sort of constants? What are the things that are still really important? Well, we still don't know what's happening to social care. We still don't know what's happening to capital on capital funding. We still don't know what's happening around healthcare and education budgets, which Sean might speak to a little in a moment. It's really vital. Simon Stevens and Jeremy Hunt were very successful in breaking away the revenue settlement for the NHS from other public sector bodies. It was done separately from the spending round. It's worth remembering that every other aspect of government is still waiting for their funding settlement, whereas the NHS's one has already been delivered. However, you can imagine the Treasury weren't entirely happy about that, and they are particularly, when it comes to capital funding, their control is particularly strong in that area. And it's no good, even if you can find the workforce to deliver whatever transformation. If you don't have the capital to buy the tech or to refurbish buildings, etc., that's going to be really hard. So that remains a really crucial thing. And of course, the political turmoil that we currently live in at the moment has some telling on that, with the Chancellor saying that if there was no Brexit deal this year, then there would be no spending review. At system level, the push towards STPs and ICSs continues. The long-term plan gave some targets around that, and the implementation guidance, which is due probably end of this month, maybe in June, depending on politics, will give more detail on that. But it was the name of the game before the long-term plan, and it's even more the name of the game now. And James will talk a little bit about this, but demand continues to grow. Demand isn't conveniently easing off as the NHS attempts to go through this transformation. And dealing with that demand while attempting to transform the services will continue to be a significant challenge. The NHS will continue to have to rebuild the aeroplane while it's still in flight. Finally, workforce challenges. They grow ever more significant. We've heard today on the radio about the number of GPs actually falling. However, whatever ambitions the NHS may have, whatever the finance it's able to get, either revenue or capital. If it doesn't have the workforce, then it's really difficult to do that. And of course, there are a whole range of other reasons, the whole range of factors such as pensions reform and Brexit, which are not playing in the NHS's favour at the moment. Right, so that's Dave's overview. Adam, your thoughts?
So thank you. So for me, the givens that you gave latterly, I think, are still there. So we're still awaiting for the answer regarding a social care assessment. What does it mean for capital? What is the journey from STP to ICS? And what to do about workforce? So those challenges we've had as a system for many years, and we still continue to face them. But on the positive part, but the earlier part that we covered, my general sense is the funding element does feel a little easier this year. I wouldn't say it feels dramatically better, but it does feel that as a responsible person for our system, it feels like we are there or thereabouts for our 1920 plan. Our finances look that the plans are credible. There is risk, but we know how to manage the risk. So that feels relatively strong, and I think I would reflect in my position this time last year. I feel much more confident about our financial position going into this year than I felt last year regarding the money.
Just on the money, do you feel, I mean, I look at the shape of the funding over the next 5 years, there is more money around this year, as Dave has noted, and you have agreed. That new money dries up pretty quickly. It falls away in the second year and then really falls away in the middle three, but then there's a bit of an uptick in year 5. Do you really feel this is the make or break year? I've got to crack on. If I don't achieve a certain momentum in the next 12 months, it's going to be really hard because the money is going to get an issue again.
Yeah, I'm with you. So I think the approach has been for our system locally is to really get the relationships into such a place this year where we can bear risk across organisations. So that's been the real difference of our system probably from last year to this year. What that creates is the ability for us to then work predominantly on a transformative system going forward. So for me, the key issue for us as a system is to really crack on with the primary care network model. So I see that as a real game changer for our system. And I think our system locally has responded really well to that. So we've got this whole process to go through May about confirming the PCN numbers, their size, where they sit. But actually I feel really confident that by the end of May we'll be in a good position for that. What I've now got to really work on with our wider system partners is to be really clear about, so the primary care network has a national sort of definition for it, but then you can locally nuance it. The make or break part for our system will be really nuancing it locally to meet our demand profile in such a way that can manage our financial position, because you're absolutely right, years 2, 3 and 4 of the settlement are the tough years, and I think year 2 for our system is the harder one, hence why we're trying to front load the majority of our transformation schemes to early in the year to make that work.
You've timing to a certain extent has worked in your favour in that your providers over the previous few years have sort of almost all turned themselves around. You've got actually a pretty strong set of providers. How important is that? How much of an advantage does that give you in that you're not dealing with? I don't think any of your providers are in any kind of distress. They're all on an upward trajectory. I imagine that's significant in the breadth of your ambitions and the speed in which you can move this year.
Yeah, so I think when organisations are in a distressed position, they often look internally to resolve their issues because that's what they've got to do, and the framework of regulation sort of asks you to do that. I think if you look at the quality of financial special measures regimes that trusts have been in historically, the majority of ours in our system have moved out of that, and that's down to the leadership of those organisations and the system. So it does give us the ability to have a different conversation, because we're not having a conversation regarding a particular regime, we're sort of out of that, and how do we get the system into a more forward-looking and a more sort of transformed financial model that we share risk evenly. So that feels better, but also I've got some very experienced chief executives in my system, so therefore it does make it easier to work with when they know their patch, they know how they work.
Number 1 chief executive in the country.
We do have Marianne Griffiths, but we also have a number of other really strong chief executives in that system who have historically worked really well together, and I think because that's quite a stable group of people people, it's sort of helped to enable us to trust each other, to bear risk and to make the right decisions to transform things going forward.
Okay, cool. Sean, the care quality and particularly how that is affected by the workforce, it really was the sort of theme of the Jeremy Hunt years. Perhaps it has been slightly overshadowed now by Matthew Hancock's appetite for technology. But just give us your overview now about in which direction care quality is going, what perhaps many new challenges are emerging, and then particularly importantly, what are we going to do about the workforce shortage?
Well, I think obviously we're talking about the long-term plan today, and I think when it comes to the areas that I'm interested in, sadly, when you talk about those things, they're largely absent from the long-term plan. That was not a mistake, that was a choice, that was a policy decision by those who wrote the plan, and we've seen, for example, patient safety removed from the plan. Essentially, the original plan was for Jeremy Hunt to, in a sense, to write the chapter for that, actually, I believe, but this was knocked around a little bit, but it was taken out, and now Aidan Fowler's got his own patient safety strategy, which is largely put off to one side and put in a box, which I think is possibly doesn't give it the importance that it needs. But in a broader context, like workforce as well was also absent, and we've seen at the moment there's big discussions going on centrally around the workforce plan. And for me,
this is the workforce plan being
the Dido Harding is
Julian Hartley are putting together.
And I think, if I'm honest, one of the sad things about the long-term plan was the absence of that, and of course the £20 billion that NHS England have got. They made the choice, not a penny of that was going to be spent to solve the workforce problem. And of course, without getting that right, you won't deliver on the long-term plan. And I think we've yet to see whether that gamble that NHS England and Simon Stevens have taken, whether they can persuade the Treasury to give them even a little bit more money for the workforce in the spending review. If that gamble doesn't pay off, then there are some really big questions around the ambitions that everyone agrees are good for the country, whether they can actually deliver that with the long-term plan. So there are some the jury is out on a lot of these big questions, but just to drill down to some specifics on the workforce, we have seen some suggestions, for example, of overseas recruitment of around 5,000 nurses a year. Now, those watching will be well aware of the national shortage we've got in the nursing workforce. We've had it for many years. Certainly all the years I've been at HSJ, we've been writing about this issue. It was created way back in the Labour government, actually. This isn't a Tory government creation, it's just never been solved by them. If the original leaks that we've seen this week are correct, of 5,000 a year, that is not in any way going to touch the sides of the workforce shortage. So we've got 42,000 shortage of nurses at the moment this year. As demand rises, as you mentioned earlier, demand is always rising, acuity of patients gets worse. The need for nurses is going to rise, so that 5,000 becomes even less achievable and less helpful to the NHS. And you see in a lot of ICS ICP plans the desire to reduce length of stay, and this is where I think there's a lot of dissonance between some of the plan's aspirations and the reality, because as any doctor and nurse and clinical manager will tell you, if you reduce length of stay for higher acuity patients, those patients require a greater level of clinical input in the shorter period of time, and you need a workforce to deliver that. And I think so we're, in a way, we're just not being ambitious enough, and the government needs to recognise that. NHS England needs to recognise that, and I think as we go forward we may have to see some of that 20 billion diverted to actually support this, because we need to solve that problem. On quality and regulation specifically, obviously the workforce and totally supports that, but I think what's for me an interesting space at the moment is the development of the ICS's ICPs and how the Care Quality Commission fits with that new structure, because the Care Quality Commission, as it is established at the moment in legislation, is a provider regulator, the CQC has been quite open that it would like to see itself get some powers to actually regulate systems.
Does system reviews, but those are outside its statutory.
And at the moment, they are done largely at the, with the permission and the direction of the Secretary of State, and he has directed them to do a few more. Those things cost money.
Yes. After you reminded him that he should be doing it.
The HSJ had to remind him, and I'm sure the CQC were very grateful for our intervention, but that isn't a sustainable position. We need to decide the future of the regulator, but as I'm sure we'll get onto, there are lots of questions around legislation and future legislative framework for the NHS, and the CQC will want its role in that. But that obviously is going to be hugely important for people like Adam as to how the system itself is regulated, including by NHSEI or whatever they end up calling themselves when it's one body.
Right, we've been joined by my colleague James. Before I come to him, I just wanted to, Adam, just a thought about workforce. It is the real, there are some challenges, particularly around capital funding and how much there will be available. But workforce, it appears to me, has just grown and grown and grown and grown as the significance. You're in a part of the country where workforce challenges are particularly acute. You've got a lot of staff from the European Union, both sort of coming on long term and coming short term. You have to deal with the pull of London. A lot of people have pulled up the good strong rail connections, so they are there are rail connections, not necessarily good strong rail connections. Surely that's your biggest headache, isn't it, workforce, in the sort of long-term delivery of what you hope to achieve?
Yeah, it's absolutely the key challenge. So we can write a great strategic plan that looks great, that the numbers all make sense. If you haven't got the people to deliver it, that's our big issue. My general sense of it is whilst I think I really welcome the National Workforce Strategy, I think we need it and we need to be clear how we do that. We need to be clear how that's going to be funded and where that sits. But I also think there is a local responsibility to nuance your offer to workforce to that local catchment area. So what we've been seeing across our STP areas, there have been some great initiatives regarding workforce retention and also skill mixing into different roles going forward. And as you alluded to earlier about some of the improvement journeys that the organisations have been on, by them I think working very hard on their existing workforce, we have seen their general vacancy rates reduce over the past 2 years. I don't think it solves the long-term issue. I think we need to be really clear about what sort of training places you've got available. So this week myself and the team were looking at the numbers of undergrad places for all of the professions, and you look at it and you say to yourself, is that really going to be enough as you profile it forward? And then you look at the aspiration of the long-term plan and say, but by I think 2028 we're going to have half our nursing vacancies. So there still is a little bit, I think, of that marrying up to be done, but I think local system leaders have a responsibility, I think, to make the case very clearly as to what their workforce deficit is and what they think the centre should be doing to help mitigate that going forward.
Okay, right, so let's telescope. Sorry, Sean, did you want to make a point?
Yeah, I just wanted to make a point on that. You mentioned retention, Adam, and I think, I didn't mention that myself, which was probably a mistake of mine, but I think we've seen a lot of emphasis on training numbers and recruitment of new blood, but of course, there's the old saying of filling a leaky bucket, and the NHS is great at this and has been doing it for 20 odd years, I think. And I just wanted to mention that there are some startling figures from Health Education England around if we kept the turnover rate, the leaver rate, at the 2012 level, so we're not going back particularly far, we'd have, I think it's something like 16 or 20,000 additional registered nurses working in the NHS today. So if trusts can flex their offer, come up with new, and we are seeing lots of effort actually being led by NHS Improvements Nursing Director Mark Radford on retention programme around the country. If we can do that, we might help to take the edge off this problem a little bit. But it's, for me, I think when you've got a 42,000 a year vacancy rate, and bizarrely that is good news actually for me, because we saw in years gone by trusts were not being honest about what they needed for nursing levels. So they were delivering plans that said we can do everything on this level, and then it wasn't working. And now at least trusts are being honest about the demand for nurses that they have, whilst at the same time we've got record employment of nurses. So those two things sitting together is actually a positive reflection of trust being, for the first time I think in in my memory, being honest about what they need. So if we can get retention right and we're being honest about the demand, there's at least the ingredients there to actually make a dent in this problem, but it's going to take years to solve, I think.
I see we have a question here about whether when and where the long-term workforce plan will be published rather than leaked. I think we think it was leaked to encourage the government to publish it. We shall see whether whether that works. In the meantime, if anyone wants to leak it to us, feel free. Was there anything else that we particularly expect? I mean, it's really, in terms of the long-term workforce plan, it's really how are we going to get the extra staff? That's the sort of key question, and all others are very much of a second order of importance. But
I think there are lots. So the leak that we saw this weekend, actually, we've just focused on the nursing workforce, but there are lots of other things that we can expect to see in this workforce plan. There is lots of talk around new roles, which can be very dangerous, as how they're implemented. But we've also seen Dido Harding discussing her response to the CARC review and the regulation of managers, and I think she's going to take a sort of two-pronged approach to that. On one hand, there's going to be quite a hard grip of this, of yes, there is going to be a register for managers, but on the other hand, there's going to be more education, training and support for managers who are in this role, and she's been very clear about wanting to sort of rehabilitate people as well as striking them off. So there are, and these are just different elements of the workforce plan. So actually, I think whilst I don't think it's going to offer us a very good solution. I don't think the proposals are going to be very credible in terms of turning around the problem that we've got. There are going to be some very interesting additional things to watch for in that plan, I think.
Okay, manager rehabilitation. That's we could spend at least an hour talking about that. Right, let's telescope backward from the long-term challenges of workforce to that of to the issue that is probably most front of mind in most healthcare systems, and that's performance on emergency care. The 4-hour, I did an interview with Ben Page, of Managing Director of the pollsters Ipsos Mori, who showed that actually people's experience in A&E was the most telling influence on how well they thought the NHS was doing, that the NHS could do something about. There were some more important things, but they were to do with age and political affiliation. So the lever the NHS can, in theory, pull is sorting emergency care performance. Now, James Illman, our senior correspondent, has joined us on that. James, not only is there a big drive to improve emergency care performance, or at least to stop it getting worse, there is also a big review of how that performance is actually measured. So tell us what's going on.
So in March, the clinical standards review was published, or at least an interim version of it. And there's 14 trusts which from this month are going to be trialling a new, what they're calling a kind of basket of metrics. Now we know the background to this, as Alistair was saying, is performance has been on the wane. The 4-hour target hasn't been hit since July 2015, so that's nearly 4 years ago, and that creates a lot of political pressure. At the same time, it's very hard to scrap a target when you're not meeting it, or at least that was the theory prior to publication of the interim report, which gave significantly strong indications that that's exactly what they want to do. So what would they move it to? So what there's a basket of metrics. It's looking at some short targets for things like stroke and heart attack, but the main thing people are talking about now is a mean target in average, an average time spent in A&E targets. Now that's complicated for a number of reasons. So the most recent data that we got is 2017-18 data, shows that the mean time was 2 hours and 53 minutes, which what does that actually mean? Because some people spend, we know, 12 hours plus in there, and then obviously some people have seen before that. Now, any medic would, well, let's just go back to what Simon Stevens said when he was interviewed last year about this, and he said that it's outdated, and why should you have a 4-hour measure for someone that's stubbed their toe or something quite minor, and also for a heart attack or a stroke. You speak to a clinician, they'll say, well, yeah, obviously the 4-hour standard is there, but obviously we would deal with the stroke, sepsis, all these areas as soon as possible anyway. So it's a slightly disingenuous argument to make. That said, there are a lot of reasons why the 4-hour target has driven some pretty bizarre behaviour. That's probably best illustrated by the spike in attendances, admissions at 3 minutes, between 3 hours 55 and 3 hours 59 minutes just before the 4-hour target. Then once you've breached, well, if you've been there for 4 hours 1 minute or 12 hours, it doesn't really matter to the target. So there are some concerns that has driven some bizarre behaviour, and people do game the system. That said, if we just move things to a mean, and we still have one totemic target for the system, I don't think that's really going to solve too many problems, because all you do is swap one big target for another, and then people find out ways to game the mean. And quite a lot of COOs are saying privately, right, if the 4-hour target goes, what is it that's going to get me sacked under the new regime? Which target do I really need to focus on? And say it's mean, well then the focus could shift to that. Now obviously that's slightly tongue-in-cheek. The patient safety will always be the kind of front of mind, but it's an issue that needs to be considered. What I think, I'll just finish here for the moment, what I think the more kind of sensible option is that there's more than one metric. Now, that has been tried, they've tried to implement this in the past. There was a review in 2010. It didn't happen for various reasons, largely political. People have been trying to do this for a very long time. Reform is required, there's no doubt about that. But let's just hope that they don't chuck the baby out with the bathwater, because the 4-hour target has also been an incredibly clinically relevant backstop.
Thank you, James. Right, we're halfway through, and I'm mindful of wanting to answer your questions. Let me address the issue of technology, and I'll use estates as well, because capital funding and related. So, as I mentioned before, there's a lot happening on technology at the moment, more, I would say, than has happened ever in the NHS. So what are the key takeaways from technology in the long-term plan, and what are some of the other issues that are running sort of alongside it? Number one, and related to primary care networks, there's the use of technology in primary care and community services. We've seen GP at hand and various other models, and the impact they're potentially making, but there's a whole range of interventions, technological interventions, and they will get prioritised. We've seen the deadline for hospitals to be fully digitised, which is the new phrase from, instead they're not paperless anymore, it's fully digital. Seen that pushed back to 2024. But more meaningfully, we have seen very clear standards come in about what that actually means, what fully digitised actually means. Beforehand, we had a sort of vague idea. Now we can really see what the end goal looks like and how well we're doing that. And because there are clear measures and targets and standards, then it's more likely that we'll get to focus on actually delivering that. Local health and care records, vital to the delivery of joined up integrated care, and they get a central place in the long-term plan. Cybersecurity. I think that still remains an existential threat, alongside workforce. Actually, I'd say they are the two existential threats to the NHS. An NHS which digitises itself very quickly to meet its whole range of challenges, but leaves itself open to cyber attack, would cut off the reforms at the knees instantly. In the long-term plan, there are 10 efficiency programs. They're a repeat largely of the efficiency programs that were in last year's planning guidance. 5 of those 10 efficiency plans rely very heavily on the delivery of technology. Now, the money that's put against them, so automation of administration saving 700 million, electronic prescribing to reduce the use of low-value medicines, 200 million. We haven't talked about cutting out patient appointments and actually reconfiguring services so there are a lot less outpatient appointments. That is a very, very significant thing within the long-term plan. And other forms of GP remote consultation, remote treatment, due to save the NHS £1.1 billion. Leaving aside the numbers, which will, naturally are guesses, the NHS's attempt to become more economically efficient is really dependent on its use of technology. Now, as people who follow our technology correspondent Ben Heather's download blog will know, the idea that technology can deliver savings in the short to medium term is very questionable indeed. Long term, yes, absolutely, but in the short to medium term. But anyway, the NHS is banking on technology making a big difference to the economics of the service. So let's talk a little bit about the Health Secretary. He's obviously incredibly evangelical about the use of technology. I would say his interventions on technology have been both positive, in that they've sent a very clear message to chief executives, and they've encouraged people in the tech world to redouble their efforts. They've been a little bit negative in that people have got a bit irritated, thinking, well, actually, we'd like you to fix the workforce problem first of all before you get too excited about technology. But if you look at exactly what Matt Hancock has been doing, his focus has been on standards. No bad thing. Actually having a clear measure of what success looks like is a good thing, rather than actually finding extra money. So while there is money around for cybersecurity, shared electronic care records, electronic prescribing, GP online consultation, the areas that we've discussed, there's not necessarily lots of money for other areas of technology. So even in this area where there is a clear focus, there are definitely winners and losers. We've also seen the creation of NHSX. That deserves a webinar completely of its own. At the moment, it's been given a very central role. And there are new people, Matthew Gould, the new chief executive coming in from outside the NHS, a new CTO, and a lot of the senior tech people moving into that organisation. It's going to be mandating standards, checking compliance with those standards, both with provider organisations and suppliers. It's going to be shaping the sort of technology infrastructure. It will be a very, very influential body. So that's the first thing. How it develops and how it operates will be important. It'll also be very significant about who controls it. You hear different messages from depending on who you talk to. While Matthew Hancock remains Health Secretary, I imagine this will be a body which leans towards the Department of Health. Once Matthew Hancock is no longer Health Secretary, I think we might see it lean back towards NHS England, but we shall see. The NHS app. Now, I think if people had discussed the NHS app 2 years ago, when it first was posited, people would have thought, it's a nice to have, The NHS app is having a more and more significant prominence as the digital gateway to the service. There are a whole range of issues about how it integrates with existing services and how it will be developed. Its use by NHS organisations and its use by supplier and its relationship with suppliers who currently provide digital services to those organisations is really quite significant. But if any of you are out there are sort of are laughing at the idea of the NHS app and not think it as particularly significant, I suggest you revise that opinion. It will be particularly central. Now, very quickly, let's talk about estates. We don't know what the money is there yet. I think there's a real sense of helplessness about the estates at the moment, because any other route other than Treasury funding seems to be just cut off every time people bid for it. Land sales are going much slower than people had hoped. The great majority of the land, the real value, is in London. Those sales are taking a long time, perfectly understandably. And then there's a question about who gets the benefit from the receipts of those land sales as well. And there's really been no strong response on what we do about backlog maintenance and how we reconfigure the primary care estate to deliver primary care networks. There's one piece of good news, which is that at a local level, the fact that you've got NHS England and NHS Improvement working together, I think will mean that the conversations about what gets invested in and how it gets invested, what priorities, will be smoother than they have been in the past. So, Adam, we've covered a lot of area there. And I want to move to questions as quickly as possible. Anything that James and I have talked about that particularly struck you, or that's particularly front of mind for you at the moment?
So I suppose probably on the 4-hour target, if I may. I'm really interested to see how the 14 pilot sites take this forward, because there's two parts for me. I've often seen the 4-hour target not just as an A&E target, it is a proxy target for patient safety and flow. So it's been what we've used as a system for quite some time. We've added other flow metrics to that, so the super stranded patient, the detox rate, all of that. So for me, what I'm more interested to see is whatever we see it replaced with, is I want to make sure I can still plot how the system is overall performing, rather than us just focusing predominantly on the 4-hour. So that's what system leaders are telling me locally that we need to make sure is in place for that, I'd suggest. And then probably to your point, Alistair, really regarding the piece we haven't really touched base, but I am finding the E and the I integration probably more straightforward than I was expecting, actually. Because we're in the southeast, we have already trialled having one regional director, and we have the same regional director. So I think for our system, it feels slightly more stable at this current point. And I think the discussions about whether it's a commissioner or provider thing, I think they are changing, but I genuinely think they will take quite some time to feel very different. So I think it's getting there, but I think for bidding for capital, for those issues, I still think it's not completely joined together, but I'm confident it will get there, but it's not there yet.
Right. I'm going to bang through as many of your questions as possible. The answers will be brief, but I will try and do as many as possible. Right, community services. So within the long-term plan, I think the aspiration is that primary care networks become the sort of driver, the way of really giving additional strength to community services. There will be some areas, however, where the primary care networks take a while to develop, where you could imagine acute providers, mental health providers, etc., continuing to be the sort of drivers of development of community services. How's it in your, and it will vary from patch to patch, how is it in your patch? Do you see the idea about primary care networks And they could, I think, probably have been called community care networks. In fact, would have been a better name for them, because the idea is that they are a broader set of workforces than just GPs delivering services in the community. What's happening in your patch in terms of that community space?
So there's a few parts for me. So we know, looking at the international evidence, that asking our primary care practitioners and community practitioners to work together just takes time in reality. So I think where our patch has got to, we're really clear that we've had quite an open dialogue with our primary care community about what a primary care network could look like. There's obviously the national DES that has come out for this year, and we're quite clear what that looks like. But we've been absolutely clear with them, and they've been clear with us, this is the start of something else. It feels to them, though, that we're asking primary care to change quite a lot very quickly, and it will take time. So our approach has been locally to give them a bit of time over the first quarter to think it through. But where we've had better working relationships with primary care and community services, they're already describing how their PCN will work and what that will look like. So in parts of our patch, our community provider is already very keen to reorientate their staff around those networks. There's probably one rub that's happening locally that I would imagine is happening all over the country. I think that I've got some really great community providers and also some mental health providers who are very happy to reorientate their staff around these networks. But they are quite clear they don't want to keep changing the boundaries. So if it's a primary care network, is that the stable unit, and will it stay roughly that size for some time so everybody can invest in the reconfiguration around that, and also the development of people to work as a joint team. So I think there's a little bit in my system of, let's see where the PCN get to, let's then orientate around it, but let's make sure we're confident about relationships before we fully throw everything into it. Otherwise we could start unpicking everything over quite a short period of time.
There are a couple of related questions here about what STPs/ICSs have learnt from the last few years. Dave, before he disappeared on paternity leave, wrote a really good piece, which I really encourage people to read, in his Integrator blog, where he talks about the kind of lessons that were being learnt, particularly about not letting the ball start rolling, that these were vehicles for cuts, and the need to involve a broad set of partners, particularly local authorities. Adam, you're running an STP in a healthcare economy that's a very different place than it was when this set of reforms start rolling. Just very briefly, what have you done differently that's got you into a better place, assuming that you are, which I'm conscious.
It feels like we're in a better place, but I think what we've done, I think we've been quite honest about our challenges together, and quite honest about what's got in the way of us having to work on them.
And when you say together, you mean not only NHS organisations, but your local authorities as well?
So what we've had to do, the NHS really had to come together and say, where is our STP, what are we doing about that first of all? And our STP was slightly characterised by we'd had an ill-defined relationship with our local authority colleagues. They've wanted to redefine that with us, but it felt really important for the NHS first of all to just be clear where we were at going forward. Having been really clear where we're at, we're now having a really fruitful discussion with the local government about what that means going forward, to the point where, because of our size of an STP, we have currently 4 local authorities working within there. We've got to respect the democratic process at place, but also I think we've managed to broker we'll respect that, but also local government will respect the fact that we're in a national system, and how you find a way of finding a win-win in situations, that's really where we've got to. So I feel what we've managed to do is build the relationships, get it into a good place, but now people are watching to say, will they now deliver it?
Fine. Right, a question on A&E, James. Figures I've seen from Sheffield indicate maybe 20% of A&E attendances can be better dealt with by other parts of the system. So you talked very much about the measures of the system, which are very important because they will drive behaviours. But, we had a lot of attention on attempting to suck demand out of A&E, or to deal with it more quickly, and to have it sort of going in but coming out again very quickly. Where's the emphasis now? Is the emphasis on dealing with that demand elsewhere, or is the emphasis on dealing with it better when it turns up at the front door?
Both. So what I would say is, for decades people have been saying that care can be pushed out into the community, and we've seen that this is far harder to do in the reality than it is on paper. What we've seen over the last few years are lots of attempts to stream patients into different areas. So urgent care centres, for example, over the last kind of 3-4 years, there's been almost kind of quiet revolution really, and lots of them popping up, and they can take away the kind of minor ailments, and they deal with them quicker. The problem is patients don't really know that, so patients find the system very hard to navigate. If you ask your average person where their local A&E is, they may well know. If you ask them where their local urgent care centre is, they probably don't. And if more people went to the urgent care centre, then they'd be seen quicker as well. So it's kind of win-win. So yeah, this kind of agenda of better streaming away to different services. They trialled over the last couple of years a so-called GP streaming model, where you had where you have a GP on the front door, and that has been pretty controversial, really, because a lot of GPs say, well, we don't have the GPs to spare, and also that's a pretty expensive bit of kit when it could be a kind of person, when it could be a sort of a BAM 5-6 nurse doing that job instead, and probably doing it just as well. So lots of work to do on that, and then obviously wider service reconfiguration as well, hoping to kind of take demand away from A&E. But I don't really see that there's going to be a quick win in that. It's going to take a long time.
Sean, a couple of workforce questions. AHPs, do we see is for a range of good, that they have skills that aren't properly used, and bad in that there's a shortage of other people? Are they going to play a more central role? And apprenticeships?
So I think AHPs certainly are a key element of the workforce. Everyone talks about nurses and doctors, including health journalists, and that's a terrible mistake, because AHPs do a wonderful job and are a key member of the team. And I think we will see AHPs being used more on wards, and you already see sometimes ward-based pharmacists and therapists, etc., and we're seeing that in the community as well.
Indeed, they're a key part of primary care networks.
Absolutely. So I think their roles will be doing new roles, as will other people. How that looks like will vary across the country. And I think, just to add there, if we think there are plenty of AHPs ready and willing to fill gaps, that's not the case. They suffer the same level of challenges as we do in other areas as well. And actually, just following up on the last point that James was talking about, moving care into community, there is a workforce quality challenge there, because I've picked up from quite a number of provider chief execs and nursing directors who are concerned that the community service staff don't actually have the skills, or they need upskilling rather, to take the higher acuity patients who are being discharged earlier from hospital providers. So the community services need to be upskilled a little bit to deal with that workload. So there's a challenge there, and if we get that wrong, obviously then people will ricochet back into A&E. So there's a challenge there for providers. But I think AHPs, we definitely will see more of them figuring in plans, definitely.
Apprenticeships?
I think apprenticeships, it's a great idea. Why shouldn't we should be able to allow people to, social mobility is a good thing, and apprenticeships have their role, but it feels to me like the NHS is dressing this up as a solution, and it just isn't. It will work for certain people who find that a useful route into a role with the NHS, but it's not a solution to the problem. In the same way that nursing associates are not all going to become registered nurses, and in fact that takes 4 years. We would have been much better had we invested money in postgraduate nurses, which takes 2 years and produces a registered nurse who's more likely to be safer. So I think apprenticeships great, but this isn't worth the it's not going to solve the problem. It may be a useful way to spend the apprenticeship levy money, which a lot of providers are kind of wrestling with as to what exactly do we do with this money. And of course, we've seen CPD and education budgets being messed around with quite a lot. So there is some help there. But yeah, I think it's a beneficial addition to the plethora of things people can do. But it's on its own is not going to solve the crisis.
Okay, we're getting very close to the end, but let's return to primary care networks again. How much in your area, of course it varies, how much in your area are primary care networks being built on what's existing there already, and how much are you having to build new things to get it going? And how do, I don't know the strength or role of GP federations in your area, but how bigger or smaller part are they playing in the creation of primary care networks?
So it's a sum and sum model. So some of our primary care networks are going to be very much identical to how the locality-based working has worked in our system. So I'll probably give an example. So Coast of West Sussex CCG, which sort of runs really from Chichester to Worthing within West Sussex, they've had a very, very strong locality network model for the last 3 years, with a very strong federation that we believe will really support them on their journey to PCNs. In other parts of our area, we've had an interesting conversation with our federations, because I do believe they've got a role to play, but they've got a role to play to support emerging PCNs going forward. And some federations see that as their remit, and if they don't, they sort of need to respond to that's the external environment, and they need to nuance to make it work there. So my sense is federations do have a role if they're going to support PCNs, or if they've been very established and they're already leading PCNs at this current point.
Thank you. Right, I'm now going to attempt myself to bang through as many of your questions as possible. There's a question about end-of-life care and it not featuring very large in the NHS long-term plan. I think if you ask Simon Stevens or Matt Hancock, they would say, yes, it's very important. I personally don't hear a lot of noise about it at the moment. So, yes, I think it's important, but I don't think it's amongst the priority issues that we've discussed. Maybe with a different health secretary, etc., it might return. Somebody asked a question on pathology services. There is a lot going on pathology, much too much for me to talk about now. But if you look at the coverage provided by my colleague Nick Carding on HSJ, you will find all you need to know about what's happening in pathology, which is significant. There are lots of, there's a question about whether NHS Digital will continue to exist with NHSX. We've debated this, I think, quite a lot in the newsroom. Our feeling is that NHSX will be the planning organisation and NHS Digital will continue to be the delivery organisation. So yes, we think it probably will. Clearly it's going to have its wings clipped, as other areas that other organisations like NHS England that were involved in technology are as well. But I think it will for the future. Indeed, you know, I think the question whether NHSX is just something that exists during Matt Hancock's time, or whether it's got a long-term future. There are questions, quite a lot of questions about the role of the independent sector in the period of STPs and ICSs. I think we have seen a real reluctance from both government and from NHS organisations to have independent sector organisations of varying kinds in lead roles on ICS and STPs. I just think the noise around that is just so great. However, there remains a range of skills, capacity and knowledge that exists, particularly around business information and certain types of technological intervention where I think the NHS, the independent sector, will continue to play a part, or the non-NHS sector will continue to play a part. You can look at Adam's healthcare economy and see the good and bad of the involvement of non-NHS providers in that area. It's a very good sort of case study. If we look at GP at hand, for example, we can see that why GP at hand gets so much focus and is being sort of jollied along by NHS England is that they're really interested in how remote care can improve the utilisation of GPs. GPs who want to work part-time, who don't particularly want to work in areas which are under-doctored. Is remote care the answer to improving utilisation in that area? Ladies and gentlemen, that's it. I'm afraid we're out of time. I apologise if we haven't answered any of your questions. I would say, looking down that list of questions, that the great majority of the answers to those questions can be found in HSJ's continuing coverage. So I would encourage you to look at that and areas of particular interest. This webinar will be reposted, so you can watch it again if you wish. So once again, congratulations to Dave West on the birth of his new boy, and we'll see you all again soon. Thank you to my panelists.